Hello, so this is nursing management of hypothyroidism. I'm going to share my screen. I just finished talking about interprofessional care of people with low thyroid. So nursing management, so the goal of nursing management is we're gonna start with assessment, right? Well, let's do a little ad pie. So, or API, depending upon who taught you. So nursing assessment, we're going to be looking at a health history. Have they had hyperthyroidism treatment? So if one of the treatment methods for a person with hyperthyroidism is to have that thyroid either surgically removed or killed off by radioactive isotopes. And so if we've killed that off for whatever reason, however that's happened, we need to replace that thyroid hormone. We'll be talking to them about changes in appetite. We'll be talking to them about changes in weight, activity level, any speech or memory or skin changes. In physical examination, we'll find that they have cold intolerance, that they have constipation, they have signs of depression, they have a decreased heart rate, they'll have a tender thyroid gland, and then they'll have generalized edema. So they'll have swelling throughout. Our nursing diagnoses for people who have these sorts of problems include activity intolerance, because their metabolism is just in slow mode. Constipation, which can be awful. Impaired nutritional status, because the food that they're taking in isn't able to be used by the system at all, either because it's being thrown back up or because the metabolism of the body just isn't able to process that nutrition. And then a lack of knowledge. Anytime somebody's got a chronic condition, lack of knowledge is a fair nursing diagnosis, because they're going to be needing a lot of education to be able to be successful with their treatment regimen. So when it comes to the plan is to have relief of symptoms, to get back to urothyroid, to get back to neutral thyroid status, help them maintain or regain a positive self-image. These people have had some very different physical symptoms along with this problem. And then adherence with lifelong thyroid therapy. Excuse me. When it comes to the implementation, most of this is taken care of in outpatient thyroid. I legitimately never took care of, in the 6 years that I worked for the hospital, I never took care of anybody who had only hypothyroid. They were there and happened to have hypothyroid too. So health promotion, we're going to be assessing for risk factors. Risk factors include being female, white, advancing age, like I had said earlier, over 60 was a common trigger. Type 1 diabetic, people with Down syndrome, anybody with a family history of thyroid problems, not just hypothyroid, but maybe a history of Graves' disease or that hyperthyroidism as well. A goiter is that enlargement of the thyroid gland. Previous hyperthyroidism and previous radiation treatment. High-risk population should be screened at regular basis for this particular problem. Mixed edema coma needs acute care. So these people will legitimately slow down so much that they will be put on mechanical ventilation to be able to get their ventilation rate up. They cannot, like, their airway is fine and their breathing is not fine and their circulation is not fine either. So if you're looking for like ABCs type deal, they will need B's and C's. Their airway is fine. They don't have any occlusions in their actual trachea or bronchioles or bronchi, but they will need mechanical respiratory support just because their respiratory drive is too slow for what a body would need. They'll also need cardiac monitoring for the same reason. Their cardiac output is too low to be able to support life. They'll get IV thyroid hormone replacement, and we'll be monitoring their core temperature. Fun fact, if you're on mechanical ventilation, we can actually put a temperature probe right down alongside of your breathing tube, and then we can get a core temperature that way. Also, if you have a Foley catheter, there's some Foley catheters that have a temperature monitor hooked in right to the Foley. So there was a couple different ways that I could get your core temperature without having to do rectals. Acute care, we're also going to be doing skin care. We're going to be monitoring their vital signs, their weights, their INO, and their edema. We're going to be that cardiovascular response to the intravenous thyroid hormone is huge. We need to really keep on top of that, because it would be very easy for a person to go from bradycardia, where their heart rate is too slow to support life, to ventricular tachycardia, or even supraventricular tachycardia, where the heart rate is way too fast. Both of those, whether they have too slow of a heart rate or too fast of a heart rate, they don't have enough blood coming out of the heart. There's not enough blood in the circulation that's getting moved in the circulation to be able to support life. So we want to make sure that they are actually like in that sweet spot where their cardiac output is appropriate. We want to also, we'll be vigilantly monitoring their energy level and mental alertness. If this person's on the ICU with mechanical ventilation, we will be doing frequent sedation vacations, and to be able to make sure that this person is can be taken off the vent as soon as possible, so that they can have they can start using this energy that we were giving them through the IV Synthroid. And then we're also going to be giving them that we can check their mental alertness that much better as well. When it comes to patient teaching, written instructions are really important. You have to remember that these people who are, their metabolism is in sloth mode, may not be able to, like, if one of the clinical manifestations is memory problems, we need to be sending home some materials that can reinforce education that can be referenced at a later time. So written instructions are really important. They need to understand the need for lifelong therapy. They cannot just stop their Synthroid. There are some different side effects of the medication, and they also need to be educated on both the signs and symptoms of hypothyroidism, so that they can recognize if their Synthroid level is wrong. They can also be getting too much Synthroid, and then they should be aware of what hyperthyroidism as well. So for patient teaching, we're going to continue on. Regular follow-up care is important. Brand switching is really important too. So once they find the right dose, there's a few different manufacturers of medications, and they all have what could be relatively the same formulary in terms of like the actual Synthroid that's in there, but the brands are going to be a little bit different about the other different stuff that's in their pills. And so we need to make sure that they're not switching brands, or if they are switching brands, we need to be made aware of it by the medical side of the team, from the pharmaceutical side of the team, the pharmacy side, so that way we can help coach and guide them through any sort of problems, because switching brands can sometimes create problems with their thyroid hormone levels, whether it would be sending them into hypo or it can send them into hyper, depending. Any sort of medication interactions, one of the biggest things that people with Synthroid need to know is they have to take it on an empty stomach. They have to take it right away. It has to be absorbed without anything else in the GI system. So a half an hour before breakfast. Like, this is the pill that can legitimately sit on the bedside table at home and be taken off the nightstand. Like, alarm goes off, take the Synthroid, and then go take a shower and get ready for your day, and in a half an hour eat your breakfast. It needs to have that standalone time, because food binds it up and gets it through the GI system too fast, and it makes it ineffective. So if they aren't taking it on an empty stomach, they will have problems with malabsorption, because the meds will get washed away with the food and it won't absorb properly. They need to make sure that they're in a comfortable, warm environment. Sweaters, cute sweatshirts, whatnot. Any measures to prevent skin breakdown. So these people aren't making enough Their sebaceous glands are also shut down too, so they're not making enough body oil, so they'll get really dry skin. Skin cracks are really easy for them to develop. They need proper foot care. They should be avoiding any sorts of sedatives. They're already slowed down because of a lack of thyroid hormone. They don't need to be slowed down anymore. So if a person is taking like herbal melatonin to help sleep at night, we may be coaching them to try alternate methods of inducing sleep that don't involve medications, because that could be interacting with their thyroid hormone as well. And people will, any sort of measures to minimize constipation, adding a little extra fiber, those low-calorie diets that we had educated on interprofessionally can be coming in here too. So if we have a person who's on a high vegetable, high fruit, low calorie diet, that can help minimize constipation too. Bonus. And then relapses will occur if the treatment's interrupted. So if for whatever reason, Synthroid isn't that expensive, but if people are having problems paying for their meds or obtaining their meds, maybe they're, I know that there are times where people will have problems just getting to the pharmacy in rural areas. If they have their treatment interrupted, they will have a relapse, and then all of that myxedema is fair game to come back on board. And evaluation, how do we know what we did work? Relief from symptoms, urothyroid state on lab diagnostics, no constipations, and or complication, which is a complication, don't get me wrong, but no complication. And they're adhering to lifelong therapy. So I'm going to stop sharing here. And that was nursing management for a thyroid or a hypothyroid. I will see you again shortly.